Norman Lavin is my name. I teach at UCLA part of the time. I have a practice in Tarzana, and I'm an endocrinologist. And we're going to talk about Down syndrome and its relationship to thyroid disorder. And I think this is very important. And we'll go through some of these things in very flexible in terms of discussion. So if you have any questions, just give a yell. So I see a lot of kids with Down syndrome, and it's quite an honor to take care of these kids. I like the kids, but more importantly, the parents I really am very impressed with, that they're able to take care of kids with challenges, and I'm impressed with anybody who could take care of anything with challenges. But to see the parents love the kids as I see them raise the kids is just very impressive and very amazing to me. So these are some of the kids that I know, some of the kids I have seen over the years. And all of you know what Down syndrome is, but it is the single most common cause of severe learning disability. And of interest that so is hypothyroidism. Hypothyroidism is a thyroid disorder in which there is not enough thyroid hormone, and we're going to explain all of this. So over the past 20 to 30 years or so, there have been some awareness about this association, but the prevalence is much greater than in the general population. In fact, 25 to 30% of all kids with Downs, or adults as well, do develop hypothyroidism, as opposed to 1% in the general population. And it increases with age, and there's also an increased prevalence of what's called autoimmune thyroiditis, which I'll explain. So I'm going to explain all these things, but if you have any questions, just fire away and let me know. Children and adults with Down syndrome should be regularly tested for thyroid hormone and antibody status. And the reason I mention it here, I mention it as well to physicians, because it is commonly missed. Physicians, my colleagues, think, well, child has Down syndrome, he's this or he's that, it's because of the Down syndrome, which may be the case, but it also may be that there is associated hypothyroidism, low thyroid function, and that is often missed. So as I say, the frequency, the prevalence is very high, and even congenital hypothyroidism, of which there is a screening test now, occurs 1 out of 41 newborns, and in the general population it's 1 out of 3,500. So it's more frequent in birth, it's more frequent during childhood, and much more frequent even in older age. So what is hypothyroidism? It is an underactivity of the thyroid gland. The thyroid produces thyroid hormone. It's important for metabolism. If none of us have enough thyroid, we just kind of go in slow motion. Think of a movie in slow motion, hypothyroidism. There's also hyper, overactive. That's like a movie in fast motion. So we call that hypothyroidism. There's not enough thyroid hormone. Clinical features of thyroid disorders in Down syndrome is confusing, and that's why many physicians miss it, because the patient is shorter, less active, dry skin, excess weight, slow heart rate, mental impairment. Well, you see that in Downs, obviously. You see it in hypothyroidism. So now if you have these two superimposed, it's missed. And the important message, again, is to have these tested, because it is possible to have somebody with Down syndrome improve. Not going to be 100%, obviously, but some improvement is better than nothing, and it's simple enough to treat. The symptoms of hypothyroidism: somebody is fatigued, drowsy, forgetful. It's many of my friends. Difficulty with learning, dry, brittle hair, dry, itchy skin, puffy face, constipation, sore muscles, a girl with irregular periods, increased frequency of miscarriages, sensitivity to many medications. So if you think about your kids, that may be true with the kids with Down syndrome, but it's also true with hypothyroidism. Now merge them together, and you have kind of a confusing picture for a lot of people. In the newborn, the kid may have prolonged jaundice. We call it icterus. There may be feeding difficulty, sluggishness. Well, that's true, of course, with Down syndrome. But this is also true of somebody with hypothyroidism in the newborn. There is now a newborn screen. By law, every baby that is born in the United States gets a screening test for thyroid. And they usually pick it up. Sometimes they pick it up early, sometimes not. But it is important if you have a new baby to check and make sure that this test was done and make sure it was normal. And if there's any question, it should be repeated. And this is not done all over the world, but it is done in the United States. So if we continue to look at this baby who has hypothyroidism, but look at the similarities with somebody with Down syndrome. Large tongue, episodes of apnea, noisy respirations, cry little, sleep more, have poor appetite, sluggish, umbilical hernia where the umbilical cord comes out, could be distended, subnormal temperature and slow pulse rate. Often missed, and this used to be missed a lot until the screening test came out, which came out about 30 years ago or so. And unfortunately, it is not performed throughout the world. Very few countries have this, which means that many kids and many places where they don't have the test, the kids are born and do become mentally impaired, unrelated to Down, just become mentally impaired because they don't have enough thyroid. So if you superimpose this again with somebody with Down syndrome, you have kind of a double whammy there. So you have to make sure that was done and check it. What are the causes of hypothyroidism? Many causes, one of which we call autoimmune thyroiditis or Hashimoto thyroiditis. Hashimoto is a Japanese doctor who described this about 30 years ago. And we're going to go into this in a little more detail, but it's an autoimmune disorder, and I'll talk about it in a few moments. But there are many causes. Radioactive iodine treatment, if somebody had that, too much iodine could destroy the thyroid. Sometimes we just don't know, spontaneous onset. Certain people have medications like lithium. Antipsychotic medications can affect thyroid function. So we need to know what the patient is taking. There's another condition called subacute thyroiditis, which is from a virus or some kind of infection, or postpartum thyroiditis. After the baby is born, the mother sometimes develops hypothyroidism. Congenital, we mentioned. Pituitary hypothyroidism. The problem could be in the brain, not in the thyroid itself. And I'll expand on these as we go. Any questions so far? Feel free to ask it. Because if I don't know the answer, the guy in the back is going to answer it for us. So, and it changes your voice too. It gets higher when you don't have enough thyroid. This is the thyroid gland found in the neck. It produces thyroid hormone, which we call thyroxine or T4. This is the base of the brain, the pituitary gland, makes many hormones, one of which is called thyroid stimulating hormone. And its job is to stimulate the thyroid gland to make thyroid hormone, called T4. In the cells, T4 is actually converted to another hormone called T3. But for our purposes here, the thyroid gland makes thyroid hormone, the pituitary makes thyroid stimulating hormone. All right? Now, if there was not enough T4 produced, not enough thyroid for whatever reason, congenital, thyroiditis, doesn't matter, there's a system, much like your air conditioning or thermostat at home, that says that if you don't have enough thyroid hormone, it tells the pituitary gland to make more TSH to stimulate the thyroid gland to make more thyroid hormone. Is that clear? So if you look here, if the T4 or thyroid hormone or thyroxine is low, it stimulates the pituitary gland to make more TSH, so that would be high. So one of the ways of making a diagnosis then is the doctor orders a test, finds a low T4 and a high TSH, that is hypothyroidism. So it's very simple. If it's overactive, too much thyroid, we call it hyperthyroidism. Some people call it Graves' disease. In that case, the T4 is high, but then it tells the pituitary, I don't need any more TSH, so the TSH is low. Otherwise, it's normal and normal. Is that clear what we said? So, simple testing. This is done in the newborn as a screening test. It can be done anytime, at any age, for the kids or adults with Down syndrome, to see if they have hypothyroidism, rarely hyper, and then you treat the patient because they don't have enough thyroid hormone. You treat them with thyroid hormone. So it's straightforward. Sometimes there are other conditions associated if you have a thyroid disorder, because the pituitary is kind of a master gland and it gets fouled up sometimes if there's long-standing hypothyroidism, which we rarely see in the general population, but we do see with the Downs kids because they're often not diagnosed. So as a result, we won't go into the great detail, but precocious puberty or premature puberty may occur. So I'll see a lot of kids coming into me at age 5, 6 who are going into puberty, not because anything's wrong with their brain or anything else, but they had long-standing thyroid failure, which has caused some problem in the pituitary. Okay, I won't go into greater detail, but to say that could occur. Congenital hypothyroidism, as I mentioned, thyroid hormone is critical for normal brain development in babies. So we tell the patients, if you have a test at birth, you're going to have a screening test, and let's say it's questionable, we're not sure. We treat the kids anyway because you have 2 years to treat the child to prevent brain damage. So it's a critical time, and we want to treat them quickly within the first week or 2. And this is superimposed again on somebody with Down syndrome, because if you have already brain compromise, it's going to get worse if you don't treat it. So if there's any question, I'm not sure, the doctor's not sure, opts to go for the thyroid hormone treatment because it's rather mild. It's not like great side effects like other medications that we use. Then after 2 or 3 years, the brain is fully developed at that time. Then we could take the baby off of thyroid hormone to see if they really needed it or not. But for the first 2 years, we just commit ourselves to doing it. So I want to make that point clear because, again, many doctors will say, well, I'm not sure, let's forget about it, don't treat it. It's a time to treat. Okay?
Is the same true with hyperthyroidism?
Hyperthyroidism is not common in the newborn period, but you want to treat it too. But this is more common for this. Okay, I mentioned Hashimoto's thyroiditis. That is an autoimmune disease. The immune system, which normally defends us against viruses and bacteria, keeps us alive so that when you get a cold, you don't die, your immune system fights you off, and that's the same thing that happens when you get a vaccination. Sometimes the immune system gets a little haywire. So instead of fighting off the viruses and the bacteria, it thinks its own organ doesn't belong there. It thinks the thyroid is foreign, so it attacks it. Itis is inflammation. So your body is attacking the thyroid for reasons that are just not clear, but it attacks it. As a result, you develop a condition called Hashimoto's thyroiditis. If so, there's a greater predilection to develop hypothyroidism because of that. Sometimes there's a goiter, the thyroid is enlarged. Sometimes you just don't know, but it can be diagnosed by measuring thyroid, so-called thyroid antibodies, which we'll talk about. So if I say, what are the features of Hashimoto's thyroiditis? Well, this list is the same list I gave you for hypothyroidism, because this causes hypothyroidism mostly. So it's the same features that we'll see in somebody with Downs, same features in hypothyroidism, congenital hypothyroidism, the same with Hashimoto's thyroiditis. So we're looking for those features which we can't always tell, again, with people with Down syndrome. What is the cause of thyroiditis, Hashimoto's thyroiditis? We really don't know. We don't know about autoimmune disorders. And let me mention some other names like lupus, you've heard of that, or rheumatoid arthritis. Those are autoimmune diseases. So this is another one. So we don't know. We know that the immune system is fouled up. If somebody wants to win a Nobel Prize in this room, find out what happened, you're guaranteed a Nobel Prize and great fame. Thyroid antibodies, anti-thyroid antibodies, are easily measured in a blood test in anybody. So to diagnose thyroiditis, we just do a simple blood test. We measure what's called autothyroid antibodies or anti-thyroid antibodies, and then we know the patient has thyroiditis. Now, some people have thyroiditis and have an enlarged thyroid gland. We call that a goiter. Some people have thyroiditis and have nothing for the moment. No symptoms, no signs, no anything. But once they have thyroiditis, once they have positive antibodies, we continue to monitor to see if they will develop hypothyroidism. Rarely they could develop hyper, as you asked about, overactive, but mostly hypothyroidism. And it is more common again in Down syndrome. Sometimes it takes a little while to treat. We treat them, and sometimes we don't see improvement right away, particularly if there's a goiter or large thyroid. But we want to treat, we want to continue treating, continue monitoring. And how is it treated? It's really simple. We replace the thyroid hormone that's missing. It's basically a tablet a day. We call it thyroxine or levothyroxine or Synthroid or Levoxel. You may have heard of those names. They're all the same. Usually we treat forever, but sometimes we don't have to. But the point is to treat as soon as you can and continue to monitor. Okay, any questions about any of this?
Monitoring, how often? Like
Well,
just once a year?
The question is a good question. How often should you monitor? And that depends on the age of the child. So a baby, I would be monitoring a lot, sometimes every few weeks. Somebody, a child, maybe every 3 or 4 months. And you and I, maybe once every 6 to 12 months. Okay? So with thyroid hormone replacement, which is simply replacing a pill, improvement is seen in physical symptoms as well as cognitive and social function. So we even see it with the patients with Down syndrome. We see improvement if they have hypothyroidism. We just don't give it because they have Down syndrome, but because they have the combination of the two. And it is probably, I think, the most missed disease in the world because of the assumption, well, they have Down syndrome, that's what's happening. And this goes back to your question about hyperthyroidism. Some of these kids can develop overactive thyroid production with thyroiditis. And if so, that's again simple. We just give a medication that reduces the thyroxine activity. We lower it, we slow it down. There's a new condition described called subclinical hypothyroidism. And normally I don't talk about this too much. It's typically a disorder that was described in the elderly. Elderly is anybody older than me, that's the elderly. And that was useful in people 65, 70, 80, and that was the end of the discussion. But there's new discussion about kids and adults with Down syndrome who have what's called subclinical hypothyroidism. It's a little difficult to put your hands around it to diagnose it, but we think it's very prevalent. We think it's important to recognize, and we think it's important to treat. There is some disagreement among some of my colleagues, but I think in Down syndrome, it's important to treat. This guy doesn't know what's going on either. This was my kid a long time ago. So this goes back to a picture that I showed you before, just a different way of showing it. This is the pituitary gland making TSH, stimulates the thyroid to make thyroid hormone, and it goes to the cells, and cells it converts to a more active product called T3. So if you interrupt the process anywhere along the line, you have a problem. If there's some abnormality with the thyroid gland, thyroiditis, it's not going to produce thyroid hormone. If you can't produce thyroid hormone, it tells the pituitary make more TSH, so you have low thyroid hormone and high TSH, like I mentioned before. Conversely, you could have overactive, too much thyroid hormone. It tells the pituitary, I don't need any more TSH, so you'd have a low TSH and a high T4. That's hyperthyroidism. What is subclinical hypothyroidism? We are not totally sure. But if we go back to what I just told you about how the thing works, usually in absolute hypothyroidism, you'd have a low T4 and a high TSH. But in this situation, you have a normal T4 and a high TSH. Well, how can that be? Well, again, going back to what I mentioned, like the air conditioning system, the T4 may have been low before we did any measurements, and then the TSH corrected it. Remember, the TSH comes from the pituitary, stimulated the thyroid to correct it. So it did, the body did what it's supposed to do. It corrected the thyroid at the expense of the pituitary putting out more TSH. So you have a condition where this is, T4 is normal, but the TSH is high. So it's as if the TSH was working very hard, extra hard, to make that normal. So then we say, well, is this just normal? Or is it early hypothyroidism? Or is it mild hypothyroidism? Or is it a new entity that we call subclinical hypothyroidism, where there is some problem, we're not recognizing it, and we're not sure do we treat it or not. So again, people that are 65 or older, is a little more aggressive treatment for them. But we're saying that the kids and adults with Down syndrome should be treated in this situation at all, as well. This is kind of beginning early mild hypothyroidism. Does that make sense? And this has to be interpreted and diagnosed by the doctor. Now, since you know that, you're going to help the doctor because he's not as smart as you guys. So there is benefit following treatment of a patient with subclinical hypothyroidism if we give the thyroid hormone, and that's why we think it is important, because we'll see a child or adult with Down syndrome, we have this kind of borderline situation, and we give them thyroid hormone, and they improve cognitively, physically, and they improve with a medication that's really rare, fairly innocuous, considering all the medications that are available. So it's worth a trial to see if this patient improves. Okay? Any questions on the subclinical hypothyroidism? Okay. So you go to the doctor, and it doesn't matter if it's a pediatrician for your kid, or your general practitioner, or your internist, or anybody else, but I think it is not only just important, but it's imperative for the Down population to be screened for thyroid problems. And I don't know if you have that experience, if your kids have been, or you have been, but it is important to screen, to test. So you want to see if there's normal thyroid function. You asked about the frequency. Well, if it's normal, I would say repeat it every year, at maximum 2 years. So you go for a routine exam, you tell the physician, can you throw in a thyroid screen? Just that simple. And they'll get a T4 and a TSH. If we see a hypothyroidism, we want to treat the patient right away to improve this person almost within a few weeks. Subclinical hypothyroidism, some doctors will say, well, I'm not sure, so let's repeat it. And I would submit to you that perhaps treatment would be a good way to go with the subclinical. Again, it's a rather safe medication, may change. Hyperthyroidism, which you asked about, we treat with medication because we have too much thyroid hormone there. And then if somebody was on treatment and they're off now for whatever reason, I'd continue to monitor that patient as well on a regular basis. Is that clear for everybody? Go ahead.
I have a question. My child is diagnosed with Hashimoto, and now we're doing the test every 3 months. But so far, no medication was given because every time we had the test, it's like going down. Now I understand that DS. I said, well, it's normal, but it's DS, D3, D4, so now I understand that they don't go together. So is it possible that it will just resolve by itself, or it needs some help?
It could resolve. Thyroiditis could resolve on its own. But I think it's important, but we don't know when or if. But I think it's important to treat the child early. And I think there'll be some, in most cases, significant difference in somebody with Down to improve them. So I think it's worth a try. But a lot of physicians are in the same place. They're not clear what's going on. Okay, any other questions? Yeah.
So is the treatment for you know, the medicine they take, is that forever, or could it be like if it corrects itself, can they at one point not need the medicine?
Congenital hypothyroidism theoretically is forever if there's a real deficiency. Sometimes it was a mistake, sometimes it was borderline, we treat them anyway, and then we take them off the medicine after 2 or 3 years of age to see if they really needed it. We call that transient congenital hypothyroidism. So in that case, we may not need it forever. With thyroiditis, we always thought that was forever, but now we're monitoring kids and monitoring the antibodies, and some resolve. Maybe it's a year, maybe it's 20 years. So not necessarily forever, but it's a long time. So most of these are long, but there are patients, as you show here, who had been on treatment, were taken off. It could have been an error. So we say continue to monitor those people, because they still may need it, may have gotten worse again, because thyroiditis could kind of fluctuate and go up and back. Okay?
If a child is diagnosed with hypothyroid at like 3 or 4, and then now they're 11 or 12, should they be taken off of it, or is that more?
Well, it depends on if they're diagnosed at age 3 or 4, we'll put it in stages. It's beyond the time where it affects the brain.
Oh, okay.
So there's no permanent damage. Or if the child's put on at 3 or 4 and they missed it from birth, then there is permanent brain damage. So that's why the earlier the better. So if somebody put on at 3 and 4 and you want to take them off at 11 because you're not sure they need to be on, then it's safe to do that if they don't need it. Okay. So look at these statistics. Who has thyroid disease? At least 13 million Americans. And half of those are not diagnosed, which is amazing because that's what I do for a living as an endocrinologist. But these are diagnosed because there's a lot of kids with Downs. They're really not monitored. A lot of kids with a lot of things that are not picked up. There are a lot of people with subclinical hypothyroidism that are not picked up or diagnosed. There are a lot of people who are not tested regularly, although it's getting a little more as a routine test when you go to the physician. More common in women, and then extremely more common as you get older. Anybody. But that's a lot of people. So if you think about it across the world, you're talking about 250 million people or so who have thyroid disease. Very common. One of the more common disorders there is. So the point of today's discussion is that I think that Down syndrome individuals are often not either tested for thyroid disease or tested and not treated, or to be critical of my colleagues, they'll say, well, it doesn't make any difference, you know, why treat them? So there's a lot of issues here, but I think it's important to be screened, it's important to be tested, it's important to be treated, and I think it does make a significant difference in their physical symptoms, in their mental ability. It may not be large, but it could be something. And I think you will be very happy having this treatment, particularly since the treatment is a really benign treatment relative to all the other medications that we use. Questions? There'll be a quiz at the end of this.
I have another question. When the TSH overworks, can that create another medical problem? It's not treated?
Is she a smart lady in the back here? What is it? And the answer is, if we go back, and I said there was a condition called premature puberty or precocious puberty. So that TSH is causing some problems in the pituitary. It gets larger and it integrates with another type of hormone that causes early puberty. So it's fooling around in there. It's not healthy for the pituitary. So the answer is yes. Other things can occur. So that's another reason to treat. And we see precocious puberty in Down syndrome. We never understood it. But one of the reasons is non-treatment of hypothyroidism, long-term non-treatment. Not for a week or 2 weeks, but a year or 2 years or 3 years.
What age is precocious puberty?
The definition of precocious puberty, the definition, which means the insurance companies getting involved in the government, is 8 in a girl and 9 in a boy, below that. But if you look at new literature, it's getting younger and younger, as you may know. 200 years ago, 16, 17 was normal, so now it's younger and younger. And there are normal African-American population as young as 6.5 in a girl. They have periods, which is normal. So by definition, for insurance purposes, for a girl has periods under 8, that's precocious period, or a boy that's developing. So if you have that, let's say that happens, you want to check the thyroid too, amongst everything else. Yeah.
So is there any correlation between hypothyroidism and behavior issues, like being obstinate or seemingly bipolar?
The answer is yes and no. Usually the more active, aggressive child with a thyroid problem is overactive thyroid. So you have too much hormone, so you're jumping around and bouncing around. And by the way, that's misdiagnosed too. I have kids coming in who are in medicine for ADHD, and they really have hyperthyroidism. They were missed.
Being monitored, and based on what you've said so far, I would call what she has subclinical. That's elevated TSH without any issues necessarily with the T4, although she is receiving a minimal dose of Synthroid. But coincidental with that diagnosis, we've noticed she's 6, by the way, so it could just be that she's a little torped, having her issues, and is overall functioning well, but she can be so ornery at times. And again, I don't know if it's just a function of the fact that she communicates better now and was always ornery and just didn't express it as vigorously, or whether it may be hand in hand with
well, I'll give you an example. About 4 years ago, a child came in and was the most hypothyroid kid I've ever seen. It was just, mother had to roll him in, did not have Down syndrome. So we put the kid on thyroid to correct it, and 2 weeks later she calls me back extremely angry. She says, "What did you do to my kid?" I said, what do you mean? He's been in 3 fights at school, so it wasn't the thyroid. We brought him up to normal. That's the kid's normal, before he had been suppressed. So when the thyroid is low, kind of sluggish, slow, bring it up to normal, it could bring out the normal
really saw that
behavior.
But at the same time, again, it's just
Right. And then some people opt, and this is parents' decision, not to treat with thyroid hormone because the kid is too active, or they'll have a lower dose. I mean, these are parents' decisions. So we'll have a range of 1 to 10, and they'll say, well, let's keep it at 2 instead of 9, because the child is too active. So those are little nuances that we go through. Yes?
Aside from medication regimen, can we supplement any nutritional you could give to the child?
There are a lot of supplements that do help the thyroid gland. In fact, in our office we have what's called a thyroid blend, and they're nutrients. It's not a vitamin per se, but you have to make sure there's enough iodine in the diet, but not too much. Because the way the thyroid works is too little is not good of something and too much is not good of something. So we've had people, particularly in the Korean community, where the pregnant mothers or mothers who are going to breastfeed are taking the seaweed soup, which is loaded with iodine. So it increases the thyroid initially and then blocks it. So it causes a real havoc with the newborn baby. So the treatment for that is don't take too much iodine. Other questions? Yes?
I'm sorry, I apologize for coming in a little later.
We took your name, we're reporting you, but go ahead.
Maybe, I didn't see anything, but did you have just a general handout of, because I just came in on the subclinic topic that you were talking about, but, yeah, thank you. But is there something, so when I do take my daughter, and she's 23, to her doctor for a physical or whatever I can to ask for this, but I just don't know what all the different types.
Let's see if we could go back to some of the numbers. So this is, the thyroid gland makes thyroid hormone. So you want the doctor to measure a T4 at least. That's thyroid hormone, all right? And you also want the doctor to measure TSH because that controls and stimulates the thyroid gland to make thyroid hormone. So just simply 2 tests, I mean there's more tests that I measure, but if you think about minimum cost and minimum amount of blood, T4 and a TSH will give information, enough information to the physician and to you, and it should be explained to you what's going on. Because it's like, you know, like you're saying, subclinical hypothyroidism, maybe we'll treat, maybe we won't. But those are the simple tests. There are other things I get. There's a total T4, free T4, total T3, free T3, thyroid antibodies. There's probably 8 tests to do. But minimally it's a T4 and a TSH.
It's just, we have a cardiologist, she has hepatitis C, and so just all these things, and it's hard to remember everything, so.
Yeah, so just ask if they measured it, and if they did, when was the last time. If it's been a while, do it again, because this could come on anytime. Yes?
So those are the 2 tests we're really asking for, to make sure they draw for the T4 and the TSH. That's what we want to
Those are the
start
basic
with,
2.
the basic 2.
But there is, what I order is a little more. I'll just tell you what I order, but that's the basic 2. T4 converts to T3 at the cellular level. Sometimes the conversion is a conversion problem. It gets a little more complex. So I'll order a T3 and a T4. Then there's also a free T3 and a free T4 and a total T4. So for example, if somebody's on birth control pills, it could falsely increase the T4, but not the free T4. So depending on what's going on, what else they're on, I'll use it to interpret. But minimally, is a T4 and a TSH should give enough information. And if they don't, I mean, more modern doctors will order a free T4 as opposed to a total T4. Do any of your doctors do that? Do you know? Are you aware of it?
What was it called? The free? What was it?
Free.
Free T4?
Free isn't free. It's free. It costs you free. It's like what they're paying me today. It's free. But total T4 was the original, but total T4 is sometimes abnormal because of things like birth control pills. So sometimes the doctor will interpret it as, oh, you have a high T4, but they really don't. The birth control pill increased the total, but not the free. So a complete doctor will get this whole panel at least one time. But then it's cost, you know, the government's taken over for cost. Okay? Has anybody here not gotten thyroid tests on their kids? Do you know? Do you know if you have them? Is anybody else on thyroid in this room? You have it? You have it? Yeah.
Hi. I just thank you for coming today, and I'd just like to let you know that our son, Isaac, at 10 years old, 4 years ago, had a thyroid condition diagnosed, and he's seeing an endocrinologist, taking DSALA every night, 10 milligrams for the past 4 years to help keep the thyroid stable.
So he's taking methimazole. So that is the question you asked. That's overactive, hyperthyroid, right?
One of the questions, because we're right now at a crossroads as parents trying to decide if we should give him the radioactive iodine to, I think they call it, to kill off the thyroid production.
Right.
First question I have with DSALA is, can a person, how many years, we're wondering, eventually if that person takes about 20, 30 years, can it affect their organs in a certain way, or is there an optimal age he should be starting? We should start thinking about doing this radioactive iodine. Is there an optimal age for him? I mean, we don't see ourselves giving him DSALA for the rest of his life. So we're trying to figure out, well, what have you seen? What have you seen?
So
He's 14 years old now.
we haven't talked much about overactive because that's not so common. But it's overactive means too much thyroid hormone. So the problem with too much thyroid hormone is, again, it's like a movie that's in fast motion. You could be shaky, your heart could be racing, you could have heart failure. A lot of things could happen with overactive. So they give a medication to block or slow down the production to get it into the normal range. In the same way that hypo, we're bringing it up to normal, we're trying to slow it down to normal, to meet in the middle. And it's not very common in kids with Graves' disorder, by the way. This is more common. So the methimazole blocks the production of the synthesis of the thyroid hormone. And you try to get a dose that produces some but not too much, and then the patient feels better and everybody's happy. The problem now you're asking is how long do you keep on that medication? There are side effects to these medications. So there are a lot of people, endocrinologists all over the world, that will say that after a period of time, depends on the age, depends on the kid. Years ago, you would not give radioactive iodine treatment. Radioactive iodine ablates, knocks out the whole thyroid gland. We would not give it to somebody under 18. And then about 10, 12 years ago, they did some studies at Mayo Clinic, and they found that you could do it with kids, and it didn't cause any problems with the offspring and so forth and so on. But there's still some questions about that. In Europe, they don't use radioactive iodine. They actually do surgery to remove part of the gland, some of the gland, or all of the gland, which we don't do too much here because there's risk of surgery, it's a scar, and so forth and so on. So after a period of 1 to 2 years, you have to kind of make the decision with the doctor, how aggressive do you get? Continue the medication, which has its own side effect, do the radioactive iodine, which should not have a side effect, but we're not sure in kids 100%, or have surgery, which does not affect the child, except there is risk of anesthesia and then scarring.
What
Yeah.
did you say about the age of 18? That
It used to be we would not give radioactive iodine under 18,
here.
anywhere in the
How
world.
long ago was that?
About 10 years ago,
About
10, 12 years ago. Now they do.
Mm.
So you have that option.
And what kind of side effects metamucil, say, take it for 10, 20 years, could it have on the organs? What
It
such
could
as
suppress
swelling?
what's called the bone marrow in
Suppress bone marrow.
your bones that make all your cells. It could get into significant problems. Rare. It's really rare. So not something I would lose sleep about, but you have to make the decision.
So he's been taking this for 4 years.
It's a long time.
18 years old is another 4 years. So
Yeah.
we're trying to figure out when could be an optimal age to, if we need to take.
It would be something I would consider doing now,
Really?
because it's 4 years already.
Excuse me.
Yeah.
We had tried alternative medicine. It was a naturopathic. He was giving him a tincture where he had, and it kind of did work. We tried, like, fish oils that are supplements in addition to regular medication. But again, the guy goes up and down. He goes hypo and hyper. So right now, I think he's going hyper again. So it's a decision we have to make now, whether we want him to continue going on medications or just getting that radioactive. Because surgery is out of the question. I know the doctor said there might be some risk involved.
Mm-hmm.
So have you heard anything like that alternative medicine working very well or
No.
not effective? No.
So you just have to make those decisions. But again, this is not common with Down syndrome. Anything could occur, as we mentioned it before, but it's not that common. Yeah.
Going back to kind of more root causes, you mentioned iodine in passing there. A number of years ago, I kind of moved away from using iodized salt when I was cooking, and I do the majority of the cooking in our house. Any risk or any concerns about maybe my daughter's not getting
Not enough? Yes. And the reason that they put iodine in salt by law is that those countries who don't have that law have a high degree of mentally retarded children as a result of not enough iodine. So they discovered it in the United States because there were some areas, like near the lakes, they had more salt than down in the south, so they saw a different degree of problems. So there is a problem with that now. It's hard to be free of salt. You go to the restaurant, there's salt with iodine and so forth and so on. If there's any question, you could just have the doctor measure iodine content, and that would give you the answer. And what do you cook?
You name it.
Okay, let's start naming, have them cook for it. Other questions?
I have a question.
Yep.
What happens when, our son is 30, will be 30 in March, and his the problem didn't start until 2 years ago, a year and a half ago. And as they increase the medicine, the T4 stays the same. It's never been high or low. but the TSH rises. Every time he increases the medicine, when he first went on the medicine, it kind of balanced. And then it started to increase again. And then every time the medicine increases, the TSH goes back up. So it's like doing the opposite of what it should be.
That is it. So
He's gaining weight, he's more lethargic.
So you're giving him more thyroid hormone, right?
The TSH,
But he's got more thyroid hormone that you're giving him.
Yeah.
Is that correct?
Well, they get the
Levothyroxine?
yeah.
And how much are you giving him? Do you know?
100 MCL.
Okay. And have you gone up to what?
No, we started at like below the 88, and then we went up to 88, and now we're at 100.
And he's a 30-year-old big guy?
Yeah.
It's an inadequate dose.
Okay.
Because that's not a very high dose for somebody who's an adult, who's a big guy.
And since he started taking it, his stubbornness and it just at night it gets
Must be related
really
to you.
bad. I mean, he's never been like this ever in his life.
So I take back everything I said. Don't treat these kids because you're going to make them normal.
So he's never had a thyroid problem, and it kind of all went together. And I don't know if it's just his age and the.
Well, I don't know if you were here when I mentioned, but this kid that I treated some years ago, and the mother got so angry because, and this is not a down, because the kid got in fights. We brought his level up to normal. Normal for him was getting in fights.
Yeah.
We didn't cause the fights.
It's normal. It's just been
Yeah.
and he's never acted like. I mean, he's
Right.
never had a behavioral problem, and just so. And at 200 pounds, 230 pounds, I'm not.
Well, he's on.
Knocking him down and carrying him around.
He's on an inadequate dose, but you may not want to increase the dose if you're going to have some more problem with it. And that's a choice that parents make. But objectively speaking, if the TSH is high and he's on 88 or 100, he doesn't have enough thyroid medication.
Okay.
Okay? Other questions?
I have a question. If a girl is not having regular periods, could that be a sign of some type of?
Yeah, I had mentioned that before, yes. That's one thing always to check. First of all, it depends on the age of the girl, but it's something to check because irregular periods at age 13, 14, 15, 16 could just be normal variation. But somebody who's 18, 19 with irregular periods, you certainly want to check the thyroid.
Another question that we get asked all the time here at the association, a lot of parents want to, because usually our kids are smaller, they want to talk more about growth hormones. What is it?
It would be so exciting if that could work. We've tried about taking growth hormone, and I have a few kids that fit criteria for growth hormone deficiency, so we can't just give it to somebody with Downs because they're short. It has to fit criteria. So these kids fit criteria, but it didn't seem to make much difference, unfortunately. So there's some kind of resistance to the growth hormone. Even in those that were growth hormone deficient, it didn't change much. But, you know, people are still doing research and looking at it. Yes?
With the radioactive iodine treatment, have you personally seen that at the hospital or you work at? Have you seen a case? How does that work? Is that like 3 days? Or what happens?
You take a pill, and it what's it called, ablates the thyroid gland. You try to get the dose that doesn't knock out the total gland, but perhaps half the gland, 2/3, but nobody's that accurate. Or some people say, let's just give a high dose, knock it out totally, and then you convert the patient from hyper to hypo completely, forever, but the hypo is easier to control and take care of than the hyper. So you're moving from one disorder to another, but with better control.
How many days in the hospital with a special needs child?
Sometimes no days. You just stay away from people.
Because in this case, it's a kid who can't feed himself. He can't
Yeah.
go to the bathroom by himself. he's gonna sit there by himself.
Right.
We're talking about isolation.
Yeah.
So.
Well, it's isolation, isolation. If you're taking care of them, you put gloves on, you wash your hands, you know. You could do it at home. Sometimes it's,
What happens, because we have younger children, and they're exposed to that?
keep them away. So you could add, you know, you could ask for one day in the hospital or isolated at home, whatever it is. That's up to your doctors, your hospital. Whatever is good for you, that's what you should ask for.
Has it ever been like the radioactive repeated? If it didn't work, then they have to try it again, or is it just a one-time thing?
Sometimes they try it again and sometimes again. Or you decide I'm going to give a big dose and just knock it out totally. So that's one time.
But he has to take a medication for life. I heard about taking.
Thyroid hormone,
Is that?
hypothyroidism. Then we convert him to we give him a new disease.
So it eventually somehow.
We don't allow you to have no diseases. We're just changing one for another, but a nicer one.
But if you get exposed, they have that radiation in their neck, and you can get it yourself if you get close to him.
It's possible, but I've never seen it.
So they give you the
Wash
proper-
your hands.
wear like a
Right.
mask and
Yeah.
everything,
Yeah.
and suit.
Don't go out to bars that night. Just stay home. Drink alone. Other questions? Okay, so the main point again is that everybody actually should be checked for thyroid problems, particularly those with Down syndrome, because I think these are the most commonly missed disorders that I've ever seen. And I see a lot of people coming to me for this, that, or the other thing. We check the thyroid and it's low. But it's missed in every population. And the screening test, of course, in this country is just wonderful. It is not found in all countries, and that means in other countries mental retardation is occurring unnecessarily because people don't want to pay the money to do the screening test, which is a shame, but that's the way it is. We actually, it was really discovered while I was training at UCLA, and we went to the governor of the state. I won't mention which governor it was, but they said no, they wouldn't do the screening test here. So the guy that invented it moved to Canada, and Canada started the screening test. And then we came back and we said, look, it's working out here. So there were about 10 of us that were very active. So we went to see the governor, and they said, no, it's too expensive. So then we had some idea, one night at the bar, I suspect, and we went to homes where they had a lot of mentally impaired kids and adults. And we checked to see who had hypothyroidism. Are these retarded because of hypothyroidism? And we found literally hundreds, if not thousands, in the state. And then we went to an economist who said, what does it cost to house these people in these homes? So once we brought that data to the governor, this law was passed that we got the screening test. And I won't mention his name unless you ask me. Any other questions? Yes?
What if, like, they kill the whole thyroid and they take the hormone every day? What if you miss one day of the hormone? Will it have...
You are reported to the police. No, it's okay.
One day and you just give it the next day, so it's no big deal.
Right. Yes?
Does it make a difference when you give the hormone in the morning or at night?
The answer is yes and no. The instructions say in the morning, before you eat. So like an hour before. So I have a lot of patients actually waking up their kids an hour before and then put them back to sleep. So I think it's a little drastic to do that. So just think of morning before you eat. So if it's not an hour, 20 minutes, you know, whatever you want to do. And the way we'll know if that, what I said is true, is we're going to measure and monitor blood tests and see how he's doing. So if we're wrong on that, we'll know eventually that that's not working. But it seems to me you don't have to follow it exactly. Okay. Other question? How many people have family on thyroid medicine? So a lot of people. Okay. Any other questions?
I'm just wondering, because you said at 18, okay, was a cutoff age for a while, And I said our kid was 14 years old and taking it for about 4 years in methimazole, and you were kind of saying she should do the radioactive treatment now. I'm kind of wondering why.
Because it's approved under 18 now, and the medicine has some potential danger. And then we suggest generally across the world that if you take it for a year or two, it's time to think of alternative medication. Okay? Yes?
She's been diagnosed with hyperthyroid, and she goes on medication. How long should they be on it until, I mean, does it ever, I know you said it really doesn't really fix itself, but.
Well, I mean, he's kind of asking the same thing. It can, because it depends what caused the overactive thyroid. Thyroiditis, which I mentioned earlier, is the most common cause of hypo, can also cause hyper. And in fact, with thyroiditis, it actually bounces around. I had one child just recently who was hypo, but kind of, no, it was hyper, borderline. So we said, well, let's wait and not treat. And then 2 weeks later, it was hypo. So sometimes you have to see where it's going because it bounces a little bit. But again, it's getting all the data together and making a decision. And you know, that's why I know this area more than the general doctor, because that's what I do. I know all these nuances and whatnot. All right? It's been a great pleasure. If you have any questions, I'll hang around for about 30 seconds. And
Thank you so much.
okay.